One of the questions that we get asked is, why can't I just use lifestyle measures to lower cholesterol and therefore avoid statins? And I think in answering that, there are a number of individual factors to take into account. Firstly, how much dietary change is there in your diet? A lot of people understandably feel that there isn't a huge amount that they can do, although I would ask everybody, regardless of cholesterol level, to have a serious look at content of saturated fats. But the other reason why we continue to offer statins is because they offer greater benefits than by simply lowering cholesterol. In order to show this, I want to go back to our diagram again, and this time explain what happens during a heart attack or a stroke. This diagram basically shows a blood vessel with a narrowed wall caused by cholesterol plaque. When a heart attack or stroke occurs, a piece of this cholesterol plaque breaks away. And because the body's natural response is to try and repair the damage, a clot is formed, and this inadvertently causes a whole blockage to the pipe. This basically means that blood, which previously would have been able to go from A to B, is now blocked, and the damage caused by a lack of blood supply is what effectively causes the damage from a heart attack or a stroke. So how does statins work? Let's go back to our diagram before the heart attack or stroke has occurred. It's thought that statins work by forming a protective layer over the cholesterol plaque, making it less likely to break off. By preventing the plaque from breaking away in the first place, it means that the clot is less likely to happen, and therefore the subsequent blockage of flow doesn't occur. So there are two reasons why statins work. Firstly, they lower LDL cholesterol, and secondly, they protect the cholesterol plaques that are already present. One thing that you may be wondering is, which statin will we prescribe? There's been lots and lots of research undertaken which has shown that simvastatin at a dose of 40 milligrams is thought to be the optimal statin and statin dose to minimise somebody's risk. There's always a chance that the higher dose we give, the greater the risk of side effects, and we clearly want to balance benefits against these risks. But overall, simvastatin is thought to be the one. You may well know people who are on different statins, such as atorvastatin, rosuvastatin or pravastatin. They are the same family of drug and have slightly different chemical compounds, but they all essentially do the same thing. We tend to prescribe simvastatin simply because that's where all the evidence is. But if you may have had problems with it in the past, then you may well have been prescribed one of these others. We would strongly recommend that you take your statin in an evening, and there's good reason to justify this. Your body processes its cholesterol at night time, and therefore, because statins are designed to interact with the way that your body processes these fats, it's important to take it at night, because by doing this you will maximise its benefit. An awful lot is often said and written about the side effects attributable to statins, and I think it is a very valid thing to discuss, because ultimately what we're trying to do is offer somebody some benefit, and the last thing we want to do is to try and prevent something happening in the future at the expense of somebody's quality of life in the present. One of the most common things that we often discuss with patients is that of muscular aches and pains. It's true to say that in my experience, when most people come in with aches and pains and the fact that they're on statins, we often find a non-sinister musculoskeletal cause for the aches and pains, and actually come to the conclusion that statins were not the cause in the first place. However, there is a very rare side effect associated with statins which causes something called myalgia. And I think what we would always say is that if you do encounter new symptoms which appear to have started since commencing one of our statin tablets, that you discuss that with us, because naturally, if it is indeed the statin, then there are a number of options open to us in order to try and minimise this. While most people like to discuss the potential for muscular aches and pains, it is important to acknowledge that there are some other potential side effects. The following list is not exhaustive, and more information can be found on the NHS Choices website. When we talk about common side effects, this is technically defined as a risk of something happening of between 1% and 10% of patients. Things such as headache, digestive upset, and by this I mean constipation or diarrhea, and effects upon sleep are classed as common side effects. Ones that are perhaps more uncommon, and by this is defined as a risk of something occurring between 0.1% and 1% of patients, are things like skin rashes, tiredness, a loss of appetite. I think it is important to remember that all medications do have possible side effects, and if you read the label on the back of any medication, you'll see a great long list. It is important, however, to balance these against the potential benefit to be had from taking them, and this is what we would hope to do with you in discussion should we recommend a statin for you. Whenever we start somebody on a statin, we always ask them to get a liver function checked around 3 months after starting the medication. The reason for this is that in a very rare situation, the statin can cause abnormalities with your liver function, and it's really important that we know about this as early as we can. But please be assured, this is incredibly rare. You may also have noticed that if you look at your blood form, that we check liver function but not cholesterol. The reason for this goes back to what we have been discussing earlier, in that it's not the absolute cholesterol level which is important when it comes to minimising your cardiovascular risk. It doesn't really matter whether your cholesterol has dropped by 1, 2, 3, because actually simply by being on the statin you will be affording yourself the very best in risk reduction that we are aware of to date. Should you decide that statins are not for you, then that's something that we totally understand. All you need to do is explain it to us, we will document that in your notes, and you can be assured that this will not be in any shape or form cause detriment to the care that we want to provide you here. What I would say to you is that I'd much rather you discuss potential problems with us so that we can genuinely find out whether they are caused by the statin, because what wouldn't be good is for you to not have the benefit of being on a statin because of fear of something that might not actually happen. So as we've hopefully explained, statins play a role in lowering our future risk of having a heart attack or a stroke in a number of ways. Yes, they lower our cholesterol, and yes, they lower the carrier protein, which is thought to deposit cholesterol in our blood vessels. But it also forms this protective layer, which is thought to make the plaque less likely to break, and therefore less likely for somebody to have a heart attack.